This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. This morning, we have Dr. Rohit Nair, who's going to talk to us about mechanical complications of MI. Dr. Nair came to us. He did medical school at University of Louisville and then residency at Duke, and now we have him here as a first-year Emory Cardiology Fellow. So, Rohit, take it away.
All right. Well, good morning, everybody. Those who don't know me, I'm Rohit. Thanks for the intro, Dr. Coley. Today I'm going to talk about mechanical complications of MI. If you ever have a question through any of this, just feel free to shout it out because I don't know that I'm tech savvy enough to also see the chat while I'm doing this. Let's get it started. I'm going to be talking about a case today that I'd for sure say is one of the most memorable cases I've been a part of in fellowship so far, and hopefully we can all learn something from it. Uh, so this was at the VA back in August during my CCU rotation there. It was a 76-year-old gentleman, no major medical history other than hypertension, hyperlipidemia, sleep apnea. He had a recent thoracic laminectomy about 5 months before presentation, but he basically came into the VAED with some pretty vague symptoms. It was 2 weeks of progressive fatigue, nausea, vomiting, dyspnea with exertion. Came with his wife, and he had generally been a pretty healthy guy before, non-smoker. He worked as a chef for a catering business. He was able to do all ADLs independently, mow his lawn. So before all of this, which started about 2 weeks ago and continued to get worse, he was a pretty healthy 76-year-old. He had no major family history of cardiac disease, and when it came to medications, he was just on torvastatin, lisinopril, aspirin, and gabapentin. So he came into the ED, and his vitals, he was afebrile. His BP was in the 80s, over 50s. Pulse was in the 80s. He was satting well on room air. He did appear to be ill. He was certainly in mild distress. His JVP was elevated to his jawline. He had a regular rate and rhythm, though he did have a new holosystolic murmur that hadn't been noted anywhere prior in his PCP visits or anything like that. His lungs were clear, though he did have a little bit of kind of a slightly increased work of breathing. You could tell he was working harder than he otherwise would be. And his extremities were warm at this point, but he did have some 1 to 2 plus pitting edema in his bilateral lower extremities. In terms of notable labs for this gentleman, he had an elevated white count to 15.4. His hemoglobin was at his rough baseline around 12. His electrolytes were okay. He did have an AKI. His baseline creatinine is less than 1, and he had an AKI to 2.28. Slightly elevated AST, ALT, 80 and 64 there. His troponin was up 2.38. BNP elevated 1,079. He did have an elevated lactic acid to 3.2 that I believe then trended into the 4s within the evening he got there. His procalcitonin was also high in terms of the initial workup we did for him. So at this point, it's sort of a undifferentiated picture. He's got a low BP, high white blood cell count, high procal. We didn't really, and then signs of heart failure, but no history of that. So the differential was still fairly open at this point. It was when we started getting a little bit more of the data that it started to become clear that this was a cardiac issue, namely his EKG here. We can see he was in a sinus rhythm, though he does have these notable Q waves in the inferior and anteroseptal leads with 4R wave progression. And then he had some pretty diffuse T wave inversions here in 1 and V3 to V6 here. So certainly concerning that something cardiac had taken place once we saw this. And I don't know how well this will show up on your screens, but I tried to take take some videos from the case. So shout out to Aisha. I don't know if she's on the call, but she was the consult fellow who initially went down to see the patient. And she had a butterfly during this month, and it ended up being quite helpful for us. So uh, not the greatest image we got here, but you can see on this parasternal long that doesn't look like the apex or septum is moving very well. Then we have this kind of more of a two-chamber view. Again, looks like the the LV is not moving, particularly in the mid to apical segments there, and the EF is significantly down. So this was all kind of the day of presentation. The patient got there at probably about 5, 6 p.m. and we knew something was cardiac. He was showing signs of being in cardiogenic shock. And so we supportively managed overnight, but we didn't have our formal echo until the next morning. I tried to get some evidence of that here. And this is when we actually started to become worried about a post-MI mechanical complication here. So I would say these are the two best views that we got. Here in this 4-chamber, we can see some Doppler flow going across this apical septum here that was concerning for a VSD. And I think you can see it even a little bit better on this short axis view. You can see some flow across the VSD there. All right. And in terms of how those studies were read, the POCUS, we said akinetic, thin septum, apex, hypokinetic anterior wall, EF of 35. And then in the echo the next morning, Dr. Linefsky read it as limited images, though EF significantly reduced with most of the mid to apical segments akinetic, along with a VSD in the apical septum. So pretty much immediately, the next thing after this that was done for the patient at the VA was to take him to the cath lab. And in there, he had evidence of elevated global pressures. His wedge was high at 24, elevated right-sided pressures, 50s over 20s in the PA, 50s over 11 in the RV, elevated RA mean. And then his index was calculated to be 2.09. And in terms of a left heart cath, they did a shunt run to confirm the VSD, and it showed a step up there between the SVC and the RV, suggestive of a VSD. LV-EDP also a bit high at 19. And angiography was not performed at this time due to the AKI that the patient had. In terms of how we managed the patient at the VA, this was started kind of initially upon initial workup when he had the elevated lactate and the low BP, signs of cardiogenic shock. He was started on norepinephrine and dobutamine for a MAP goal of 75, went ahead and loaded with aspirin, was started on a heparin drip, just in case there was an additional potential distributive component with that elevated white blood cell count and the procalcitonin. He was started on broad spectrum antibiotics. I think we did vancomycin. When he was in the cath lab, he had a Impella CP placed. And then we talked to CT surgery early that second morning, and they recommended transfer to EUH for upgrade to an Impella 5.5 for improved cardiac output augmentation, and then ongoing surgical plan over there. So it's the patient eventually made it over to EUH. Shout out to Alexis, who was covering the CCU that afternoon because I had clinic. I think he had to, they needed someone ACLS certified in the ambulance. So I think he went with the patient to EUH. And I just hope they gave him a round trip. But in terms of the course that he had at EUH, he was immediately upgraded to an Impella 5.5. CT surgery saw him, and they recommended ongoing supportive care for 2 to 4 weeks to allow for tissue remodeling prior to attempting a VSD closure. He did have a TEE to kind of delineate the extent of the defect, and that confirmed an at minimum 1.7 centimeter apical muscular VSD present with left to right shunting. And then in the course of the 10 days, the patient was alive at EUH. His renal failure worsened. He was initiated on CRRT, developed a high VT burden, which required amio. I think pretty early on in the course, there were some good goals of care conversations that were had, kind of describing how high the mortality is for his condition, and he was made DNI DNR fairly early into it, but still was had the Impella in place and wanted supportive care. But through the course of about 10 days, he had continually escalating pressor requirements, became significantly encephalopathic, and when he was already DNI, had developed acute hypoxic respiratory failure despite being on 3 pressors and having the Impella in place. So within about 10 days from initial presentation, he was transitioned to comfort care and unfortunately passed at PUH. But as we'll get to talking about here a little bit, that's not out of the norm for having a post-MI mechanical complication without surgical repair of a post-infarction VSD. Historical studies have shown that up to 90% die within 2 months, and even if you get it surgically treated, it seems to be around 50% is the mortality there. So in 2021, the AHA released a consensus statement highlighting that high quality evidence to guide the management of mechanical complications in MI is sparse, and that international clinical practice guidelines for the management of STEMI lack a comprehensive discussion on therapeutics and multidisciplinary management needed to tend to mechanical complications. So a lot of what we'll talk about is based off this kind of guidance, because certainly now it's something that's rare enough to where there aren't clear guidelines based off of randomized clinical trials like we have in a lot of other aspects of cardiology. So this is a chart of the 3 major complications with high mortality of MI that I wanted to touch on today. So that's post-MI VSD, papillary muscle rupture and resultant MR, and then free wall rupture. This chart kind of highlights the low incidence of this being around 1 to 6%. I would say more studies tend to lean towards it being the lower end of that range. Certainly in the reperfusion era, we'll get to talking about that a little bit. But again, this highlights that they all have a slightly different classic presentation profile, and that mortality is at the very least at 40 to 50% for all of these complications. Thought it was good to, and they mentioned this in the AHA guidance, to think about the non-MI related differential diagnoses when a patient's making their initial presentation. Of course, you'll get a lot from the physical exam and the workup that should be done in the ED, but some things to think about as alternatives would be dynamic LVOT obstruction, acute PE, cardiac tamponade, acute aortic dissection, and of course septic shock that can all lead to a similar type of presentation. And it's always worth keeping in mind that one of these is not going on along with a mechanical complication of an MI. So again, to get to the incidence of it, they occur at a rate, the latest data we have suggests they occur at a rate about 3 per 1,000 patients with acute MI, most commonly occurring after a STEMI. The underlying pathophysiology of all of these mechanical complications is tearing of necrotic myocardium. VSD is reported as the most common, occurs in about 1 in 1,000 STEMIs, and free wall rupture the least common, though free wall rupture is likely underreported as it often occurs with out of hospital sudden death. Prior to the widespread use of reperfusion, it was thought that free wall rupture occurred in about 2% of acute MIs. And this was, I thought, interesting. There was one study showed an increase in the risk of mechanical complications after an MI during the COVID pandemic, theorized maybe due to a delay in presentation, lack of hospital facilities. So this was just a single center study done in Japan. So don't know how generalizable it is, but did find that interesting. And the in-hospital mortality rate for a mechanical complication, any of those three that we mentioned, are 42.4% after a STEMI and 18% after an NSTEMI in the reperfusion era, despite the increasing age of this cohort. There's been historic studies. There's a wide variation in what the actual mortality range is estimated to be. You'll see some studies that say it's more like 50%, some that say it's more like 90. But I think most studies tend to say that the overall mortality rate is decreasing despite the increasing age of the cohort. So this study came out in JACC in 2019. And it has the best current estimate of the incidence of the individual complications in the reperfusion era. It was an observational study of over 9 million MI hospitalizations between 2003 and 2015. So in the reperfusion era in the United States, the in-hospital mortality rate that I just mentioned, that 42.5% for STEMI and the 18% for NSTEMI, also came from this study. It was interesting that both mortality and incidence generally remained stable through this study period. The mortality did increase as age of the patient increased, and there was also a significantly higher mortality in women with mechanical complications after having a STEMI. So to get to talking a little bit more about the individual complications, for a post-MI VSD, the onset tends to be within 24 hours, though it can be up to 2 weeks. The size of the defect itself determines the magnitude of the left to right shunting and the likelihood of survival. Risk factors for a post-MI VSD have been shown to include single vessel disease, particularly of the LAD, poor septal collateral circulation, and then also a late presentation. In terms of manifestations, there's a range, of course, can range from just a murmur to mild dyspnea to severe cardiogenic shock, as we saw in our case at the VA. Of course, left to right shunting can lead to right-sided signs, symptoms of right-sided heart failure. And then often there's a new cardiac murmur that's harsh, loud, polysystolic. Up to 50% can also be associated with a thrill. In terms of diagnosis for a post-MI VSD, TTE, of course, and then you can get a TEE to delineate the complete extent of the lesion. LV angiogram in the cath lab can help diagnose it. PA catheter to get the to do shunt runs on that can help identify one. And then if a patient is in the rare case that they're hemodynamically stable enough to tolerate it, can also be seen through cardiac MRI or cardiac CTA. In terms of management, the most important thing is CT surgery consultation. And then, of course, afterload reduction to decrease the left to right shunting, oftentimes done with nitrates if able to be tolerated. Coronary angiography, that's mainly to determine if CABG may need to be done, as well if a surgery were to be performed. Mechanical support, though mechanical support does not have any impact on the outcomes for these patients, and that's kind of widespread amongst all three of the major mechanical complications. And then, of course, vasoactive agents. So one thing that's controversial is the timing of a VSD repair. So many surgical studies show lower mortality rates with surgery a few weeks later once you let some of that myocardium heal. But there's likely a pretty significant selection bias there, and of patients and selection of patients who are not in shock and also have smaller defects. But even if in reading up about this, you can see that, like per the experts on Up to Date, they kind of make a statement that generally surgery should never be delayed to allow for fibrosis of the septum, as most will not survive this delay. Again, up to 90%. But the AHA statement takes a little softer stance on that, and there's more support for waiting, especially if a patient is hemodynamically stable, because there are frequent surgical complications after performing a VSD closure in the acute phase, including having a residual shunt. There's a lot of work that's being done in investigating percutaneous VSD repair, and those interventions are being developed even as a bridge to a more definitive surgery, though data on that's still limited. And there was one study that I think had about 30 patients in it that showed that survival is 35% at 30 days, even with percutaneous intervention. And it's much less than that in patients who were in cardiogenic shock. So a lot to think about there. And I think that's why it highlights the importance of there being that multidisciplinary discussion in the care of these patients. Overview of the imaging. I didn't get to have the images for the TEE of our case earlier, but would imagine it looked something like this. This is the TEE view of an apical post-MI VSD, and then here you can see what it looks like on a gross pathology image. For papillary muscle rupture, onset, a generally similar time course, about 2 to 7 days after an infarct. It most commonly involves the posteromedial papillary muscle, and that's due to the fact that the posteromedial papillary has a single blood supply from a PDA, whereas the anterolateral has dual supply from the LAD and the circumflex. So risk factors, again, similar to the post-MI VSD, poor collateral circulation, single vessel disease, and presentation as a first MI. Manifestations, acute onset hypotension, severe pulmonary edema, and you can hear a mid-late holosystolic murmur, though oftentimes they will have none, particularly with the larger defects and the greater amount of regurgitation. Interesting to note that a thrill, though, is generally not present with a papillary muscle rupture. Diagnosis, again, a TE. You'll see a flail segment of mitral valve, oftentimes a severe eccentric MR jet, and then the severed papillary muscle or chordae freely moving within the LV. And then TEE is also generally done. You most likely will need a TEE when the ruptured head does not prolapse into the left atrium, which occurs in up to 35% of cases. And then an LV angiogram, of course, can also be helpful in identifying this. In terms of management, again, CT surgery consultation. Emergency surgical intervention is the treatment of choice. And in contrast to VSD, it does not involve necrotic myocardium within the suture lines. So it has been shown to have a lower mortality than VSD surgery, though it is still high. And then again, a common theme, afterload reduction, nitrates, diuretics if the patient is able to tolerate those, vasoactive agents if the patient's in shock, and then mechanical support. Regarding the surgery, it's interesting to note that replacement rather than repair is the treatment of choice, and that repair should only be attempted when there's no papillary muscle necrosis itself. But that's another area where people are trying to see about developing uh, new interventions to hopefully over time improve the mortality rate for this condition. And then here we see a TEE view of ruptured papillary muscle in the left atrium. Again, this is appears to be a posterior medial defect, and this here you can see the ruptured muscle on a gross image. And getting into LV free wall rupture, the onset of that is generally within the first 5 days for half of the cases, but up to 2 weeks. In over 90%, they will present within 2 weeks of the initial insult. It more often involves the left ventricle, and those early ruptures that occur kind of within those first 5 days present with an abrupt slit-like tear with a preference for anterior infarction sites, whereas the late presentations are often more so just infarct expansion, and those tend to have a less anterior preference for where the defect is. Risk factors, again, most of these are from the pre-reperfusion era, but first MI, STEMI, anterior MI, age greater than 70, female. There is quite a low incidence of this in the PCI era, and a limited report on what the kind of newer risk factors are, like I mentioned. And manifestations of this are also variable, but prior studies have shown that PEA in a patient with a first MI without overt heart failure does have a high predictive accuracy for LV free wall rupture. And it can and that's generally what happens when you have a complete rupture. But you can have an incomplete or a subacute rupture where an organized thrombus seals the ventricular perforation. And that can typically have one of 4 outcomes. You can have frank rupture with cardiac tamponade and hemodynamic compromise, or you could have a formation of a false aneurysm that's walled off by pericardial tissue. You can have communication with the left ventricle through that perforation, or you can also have the formation of a left ventricular diverticulum, and diagnose that with an echo as well. And then they may have more of the clinical or echocardiographic signs of pericardial tamponade. And then MRI is the modality of choice if it's one of those stable subacute covered ruptures, if patient is stable enough to undergo that. Then, of course, the echo will show effusion with the evidence of chamber compression, and many do not survive this acute phase, though, due to the immediate cardiogenic shock and PEA. So, like I mentioned earlier, the actual incidence of this is likely underreported. Not the greatest images here, but you can see evidence of tamponade, and particularly tamponade that's gathered around the LV rupture site, and then this seems to be a transmural infarct rupture across the LV lateral wall there. And so one thing that that AHA guidance really highlighted was a team-based approach, and how I think that's the biggest takeaway from that statement was that it highlighted that it should be a multidisciplinary approach with the patient's goals at heart, and that should, a typical case of this should likely involve a palliative care team, cardiac intensivist, CT surgeons, and then interventional cardiologists. So there should definitely be this. I think it's good to keep this kind of outline in mind when caring for patients with a mechanical post-MI complication. And then this was mentioned in the statement in terms of future directions as to where there are gaps of knowledge that could be that need to be further researched. And that's the role of POCUS in initial assessment. It certainly helped in our case that I described earlier. It was really the the best objective data that we had earliest on that suggested that it was a primary cardiac issue, and I think that helped us in our choices that first day that we had the patient. And the actual role of cardiac CT and cardiac MRI, and when we were able to do that, and how that could impact surgical planning, I think that still needs to be delineated further. Then the role timing of LV support devices and ECMO. There's still, like I mentioned, there's no mechanical support that improves the mortality for these patients. But are there certain timing things that could change? I think it's tough because the incidence of this is so low that it's hard to really get enough of a data set to have better answers for some of these things, which is a blessing that it doesn't happen as much as it used to. But I think that's something that people want to look into further. And then, as I mentioned earlier, the timing of surgical or percutaneous correction. I was looking into it. I know people are working on like 3D printing technology as patches and this sort of thing for percutaneous interventions. So we'll see what the future holds there. Other than that, I know I kind of zipped through that, but here are my references, and open to any questions or discussions. But that's what I got for you today.
Thanks, Rohit, for a very interesting case presentation. As I was saying to Rohit before he started, and I know this patient from the VA, I think a veteran who waits a long time to come in is probably where you're going to see some of these complications. But I'd be curious to hear about others' experiences on how often they see things like this.
Hey, Robert, Steve Clements.
Hey,
That was very good.
thank you.
So it's always interesting to me to step back and say, well, how do we diagnose ruptured septum? And you say, well, you diagnose it with an echo or whatever. Often the nurses diagnose it in the CCU when they listen every day. They say, we've got a new murmur over here, and you listen. And you say, well, a new murmur in the ICU is either VSD or ruptured papillary muscle. And if the hemodynamics are good, then you can hear the murmur VSD, and you can do the echo. And if the jet is coming toward the transducer, you can calculate the RV systolic pressure. And that's one time when you know that diagnosis is present and the murmur is loud, because when the murmur gets less loud, that means the hemodynamics are going the wrong direction. And we've had a lot of these patients here at Emory and Emory Midtown, St. Joe over the years, and it's always hard to know what to do. And it's always hard to get them through this. I remember a story that Dr. Hurst told one time. He had a patient that he diagnosed over the phone. The man was in Puerto Rico, so he called Denton Cooley in Houston, and Denton said, send him on out, and Denton operated on him and survived. And Dr. Hurst said, well, we have trouble getting these people to survive surgery. And Dr. Cooley said, we get them all to survive. And the bottom line of that is, if they can get out to Houston, they become survivors, and they scar their VSDs down. You have something to sew to. I've always been interested also in ruptured papillary muscle, and all the things that you said about the coronary circulation is true. But oftentimes these people get into stress early on, get on a ventilator, so much noise, you don't hear a murmur. And the one clue to the fact that something is going on is the fact that the ventricle is really squeezing. Even though there may be an injured wall, it gets pulled in by the dynamics of a left ventricle that has tremendous afterload into the left atrium. So they can sit around on the ventilator with pulmonary edema for a long time before we finally make the diagnosis. You many times can't see the papillary muscle floating back and forth. There's some degree of mitral regurgitation. But if you have someone that goes into pulmonary edema suddenly and they have a dynamic left ventricle, keep looking for ruptured papillary muscle. EKG changes sometimes are not so dramatic in contrast to VSD, which often they are revealing. So thanks for that presentation. That was a wonderful review.
Thank you. I appreciate that.
Thank you, Dr. Clements. That was a great kind of summary of physical exam findings and bedside pearls, actually, that are very, very important. Thank you for reminding us all about that. And to Dr. Coley's answer, it appears that these post-MI VSDs also come in some sort of cluster. I just was involved in a case very similar. I was actually thinking that, Rohit, you are presenting that case. It's very, very similar. However, it wasn't a VA patient. It was a patient that was transferred from us from Southern Georgia. Very similar MI. However, this was not a late presentation. However, I think by our interventional cardiology team, they felt that they intervened on a non-culprit vessel in a setting of a STEMI, and that led to a delay in revascularization, post MI VSD. Now, unlike your patient, similar, had his Impella CP, was brought up here, and we upgraded him to a 5.5. Unlike your patient, he did okay initially, didn't require any intubation or so, was very kind of quote unquote those stable patients that you would label. However, of course, over the course of time, he deteriorated fast, despite adequate kind of hemodynamics for in the beginning of his presentation, but kind of goes on the spiral down. As you mentioned, the mortality is extremely high, and chances of them surviving, even with surgical intervention, is kind of a flip of a coin. However, yeah, that was a beautiful summary and kind of reminds us of complications that we need to look for, especially treating these any MI actually. Yeah. So thanks for doing that. And question to you was, what do you think, in your opinion, I know the evidence is not strong yet, but from your review on this topic, do you think that further, advancement in mechanical support, especially with adequate unloading, may help in this situation? What's your gut feeling, Rohit, about this?
I think I can, more than I think Impella or balloon pumps, I can maybe see a role for ECMO doing a little bit more.
And actually, that's you fell into kind of you fell in my trap kind of thing. I was gonna ask you, do you think ECMO will be a better stable and better platform of support in these patients? And I can argue with you, it's probably not. But I'm curious to see what you're going with this.
Yeah, just in terms of like when I think about it, like it never is. I mean, it would always be a bridge to get them to surgery, right? So I feel like that's the ultimate. Or I haven't necessarily heard of any of these patients getting a transplant, but I mean, it's tough. I would think, yeah, everything that's been done so far has shown that it doesn't improve mortality. So that suggests that they're not even necessarily getting to a place where they're able to tolerate the surgery on any consistent basis. But, physiologically, I mean, it makes sense how you could improving the, if they're in shock, improving the output with an Impella or balloon pump also reducing the afterload would all be helpful. But at the same time, I feel like if they have a mechanical defect that's not being tended to, you're kind of spinning the wheel. I don't know if that made sense at all, but that's just me talking out loud.
Yeah, no, you're right. I mean, I agree with you. ECMO, despite being the shining star here in the mechanical support arena, however, I think ECMO, of course, at that point when the patient is almost dying, you want to do what you want to do, what you can do, and especially in the goals of care discussion in the beginning. And this is more for our junior fellows who are going into faculty soon. Goals of care discussion is extremely important here. The chances of this patient surviving is extremely low. And, ECMO, although it's a kind of more of a, the highest level of support, however, that pathophysiologically and hemodynamically may put a lot of burden on that LV that's already struggling. So it makes more sense to see, it would have been made more sense if we were to see better survival outcomes with Impella unloading. However, that wasn't the case. At least anecdotally, I don't think there's going to be a clinical trial to do that. Because, like you said, it is, it's going to just continue worsening. So, yeah, I was just wanted to see if you would mention the ECMO, and I'm glad you did. So that was exactly my point. I think if any mechanical support platform would be ideal from a hemodynamic standpoint, it will be an Impella and then a balloon pump. But even with those, your mortality is still high. Thanks, and good job. Wonderful discussion and a very good topic.
Thank you.
You mentioned that there are some structural devices that are being looked at. Are there any wins in any of those devices?
I think in terms of those devices, they're more so in the realm of percutaneous closure devices for VSD and also like patches for free wall ruptures. And there was, for the VSD patients, there was one study, I think it was single center, maybe 35 patients. And the mortality of that was still, let me try to remember the exact numbers, but I think only about 35% of the patients survived those percutaneous VSD closure interventions. And like, if they had cardiogenic shock to begin with, then even less. So I don't know that any of what's been developed has shown to significantly increase or decrease the mortality rate, at least not in what I looked at.
Of course, the reason for the decline you implied correctly is that these people get treated early and get treated for the infarction before they necrose the whole myocardium. This idea that the median time is 24 hours, is for ventricular septal rupture is probably incorrect. They probably are much longer because, when did the infarct occur? And like in this patient, we don't, do you know when this actual necrosis started with this patient? It was obviously well developed at the time. So the treatment that works, of course, is to prevent it, prevent the rupture. But once it happens with a septal rupture, in my experience, ones that have survived, a lot of them are not really in the septum so much. There's kind of a rupture, particularly inferior apically, where the rupture is from the left ventricle around through the wall and into the right ventricle, and there's a lot of tissue there to sew to, and this is a better situation than say rupturing the middle of the septum or massive necrosis where the whole ventricle is very hypokinetic. But if you got everything working, but you got a smaller rupture, maybe a big flow, but the rupture is in the apex, particularly inferior wall apex, then things can be pleated and sewn back together. Then some of these are probably the ones that do survive. It's, one of the problems, of course, is the surgeons don't see this very often. So, it's not like there's going to be surgeons with a whole lot of experience of treating them. It would appear that imaging, probably has with the CT and MR, we have a better way of figuring out which ones could be treated, and maybe some of these could be treated earlier, where they're developing, systemic, the shock is killing them from other organs, and maybe this could be intervened on earlier if you could figure out which ones the surgeon could do something constructive for.
Appreciate that perspective. One thing I was kind of wondering, just for the group, there's some mention, in when I was looking at this, that some patients historically have received a transplant for this. Has anyone seen that around here? Or I would imagine that very few patients would be in a space to tolerate that with a condition like this, but it was mentioned as a possibility for someone.
Well, they've got to survive for
Right.
for a long time. Yeah.
Appreciate everyone for the kind words and for listening to me today. Look forward to working with everyone I haven't yet. Happy holidays.
The preceding program is copyrighted by Emory University.